Hi everybody, and welcome to my capstone project entitled Advanced Epidural Management for ICU Nurses. My name is Katie Early, and I'm a registered nurse working with the acute pain service here at Dartmouth-Hitchcock. Just a little bit about my background as a nurse. I've worked in the intensive care unit for about 6 years. Prior to transitioning to this position, and truthfully I never felt completely comfortable caring for a patient with a thoracic epidural. I always had a lot of questions just regarding the process, really trying to understand how an epidural works, trying to visualize the way it works, and so I felt that this would be a great topic. This would be a great topic to discuss for my capstone project in order to enhance nursing comfort and knowledge regarding thoracic epidurals. And so why the need for epidural education? Along this process, I realized that the hands-on epidural education has actually been removed from initial orientation here at Dartmouth. Sadly, no follow-up education or competency for epidural management exists, and the only reference tool available is an epidural management poster on each unit. From my observations in the ICU and through my own experience, I found that nurses don't always seem completely comfortable with epidurals, and there tend to be just a lot of questions and concerns about them, and so I felt that developing an educational tool, a follow-up educational tool for advanced epidural management. And so the purpose of this project is to develop educational tools to enhance nursing knowledge of thoracic epidurals. The goal of the capstone project is to create a variety of educational tools for nurses managing epidurals. And so the first step is to provide a discussion or teaching session, which is happening right now, today. You are involved, so I thank you for your attention. And in addition to today, the future holds that I will develop an information sheet for the ICU website with epidural tips and tricks, along with a video tutorial for halogen created in conjunction with the Simulation Center, which I hope will be an expectation of all nurses within DHMC, as well as contributing to the annual competency that is held within the ICU each year. And we basically call that a skills development day. And so the goal is for thoracic epidurals to be included within that skills day. And so in thinking about my research design, I used a convenient sample of registered nurses in the surgical ICU. I reviewed a variety of literature about epidural management and used inclusion and exclusion criteria in order to comb through that literature. I decided to use 8 sources to provide evidence-based research and high-quality evidence that was unbiased, objective in nature, and relevant to my topic. And so evidence-based practice was collected, and so now the purpose of this session is to communicate these findings, communicate the education or education related to epidurals, the most recent evidence-based practice, and that is going to happen right now. And so let's start from the very beginning. What is the purpose of a thoracic epidural? The purpose is to provide pain relief by continuous administration of pharmacological agents into the epidural space via an indwelling catheter. Ultimately, an epidural provides better pain relief than parenteral opioid administration. And in today's day and age, with the opioid crisis that our country is struggling with, thoracic epidurals are a great alternative to achieving wonderful pain relief while avoiding the use of IV opioids. And so what types of patients are thoracic epidurals used for? Ultimately, patients undergoing any type of extensive open abdominal surgery. So those are our liver patients, our Whipple patients, anybody undergoing exploratory laparotomy, esophagectomies, thoracotomies, anything with a really big incision in the thoracic cavity. In addition, we use epidurals also for trauma patients that have injury to the thoracic cavity. So let me give you an example. In the surgical ICU, we oftentimes have trauma patients with multiple rib fractures, and the rib fractures are so incredibly painful. They prevent a patient from coughing and deep breathing, and so this is where a rescue epidural comes in handy, where we can put a catheter into a patient's epidural space, deliver numbing medication, and they can breathe easier, rest easier, and overall they have a better outcome. And so let's review just some basic spinal anatomy here. The epidural space is the space that lies between the walls of the vertebral canal and the dura mater. It is a space, and you can see here in the image, it's a space that is yellow in nature, just representing the fat molecules within the epidural space. The spinal nerves emerge from the spinal are hitting the epidural space, and so that medication can be absorbed into the nerve fibers here. You can see here the purple area represents the thoracic cavity. Is within this purple area that we place our thoracic epidurals. So if you look to the right, you will see the spinal column and the vertebrae. And so if you look at, let's say, T7 and T8 on the right side along the spinal column, and then you look over to the left and you see this gentleman in the supine position, you can correspond T7 and T8 to that area right below the nipple line and above the umbilicus that will really target any abdominal surgery, such as an exploratory laparotomy. And that incision will be right there around T8, T9, and we can calm those nerves and provide pain relief for a patient. And so what exactly is a dermatome? A dermatome is the area of skin that's innervated by a given spinal nerve. So taking a look again at T7 and 8 and then going to the left and understanding where that hits in the front of the body. And so how is a thoracic epidural placed? So very exciting here at DHMC, we actually use X-ray technology in order to guide our catheter placement. We are one of the only hospitals in the country to use this really unique technique, and the reason why we do that is because we feel that epidurals are more successful if we know, and pain is better controlled if we know exactly what dermatome we are hitting. When we know the dermatome that we are hitting and the epidural space that we are hitting, we can provide better pain control for the patient. And so with that said, I'm going to actually bring you through a little tour of epidural placement here in our hospital. Once we've identified a patient as an epidural candidate, we greet them in same-day program, which is on the 4th floor. We ensure that we have anesthesia and procedural consent before we bring them to OR 19. Here you will see the entrance for OR 19, and And this OR is the OR where we perform all of our epidurals using fluoroscopy. And so now I'll take you on a little tour of our very special OR. Here you will see the table that the patient lies flat on in the prone position. Their head is face down, resting comfortably in the pillow. Next is our C-arm that provides x-rays for us of the patient's spine to ensure catheter placement. Here you see our sterile field with proper instrumentation for epidural placement. Next is Matt George, one of our wonderful APS nurses who's providing sedation for this patient and also monitoring their vital signs. And lastly, here is our team in strong discussion about their upcoming case. And so the next step after getting the patient set up, we take a picture of the patient's spine just to get a general sense of their anatomy. Here you can see the target zone, which is the epidural space. That's where we want our catheter to be placed to provide pain medication. And in the next few minutes, you will be able to see the exact procedure that we go through. Next step is we actually take an x-ray of the patient's back to see where that needle is in the spinal anatomy. Next, our physician attaches a sterile saline flush to the TUI needle. He begins to advance the needle while pressing the top of the syringe. He does this in order to locate the epidural space or target zone for the catheter. The saline easily flushes through the needle when the epidural space is found, which can be seen right here. Once the epidural space is found, he detaches the syringe and retrieves the epidural catheter. The catheter is a flexible plastic tube that will eventually stay in the patient. It provides numbing medication directly into the epidural space, numbing the nerve roots in the target area, which ultimately provides pain relief for the patient. The catheter is inserted and an x-ray image is taken to see exactly where that catheter is. The goal is for the catheter to be centered and straight for equal distribution of medication. This x-ray image shows that the catheter is kinked. Do you see it? This image shows that the catheter tip is more towards the left. So, this patient would actually be numb on the left, however, not getting any pain relief on the right side. And this last image is a perfectly placed catheter, midline and straight, ending at T8, T9, which will provide pain relief for this patient undergoing a hysterectomy. In order to confirm catheter placement, contrast dye is injected into the catheter, mimicking medication. Here's a live film as we inject the dye. Be sure to look for the darkening areas. This shows us the spread of numbing medication in the epidural space, which will numb the nerve roots in the targeted dermatome.
Yeah. Bilateral, up, down. Oops. Got some stuff in there that looks pretty pathognomonic, like epidural space. That's a thumbs up.
Once placement is confirmed, the TUI needle is removed, but the white catheter stays in place. This provides numbing medication and pain relief for the patient. A sterile dressing is then placed over the insertion site, and Tegaderm is used to secure the length of the catheter on the patient's back. A stat lock device is also used to secure the catheter in hopes that the catheter does not migrate. Through this process, we can achieve optimal pain control for our surgical patients while reducing their opioid requirements. This concludes the process for thoracic epidural placement. And so let's actually come back to take a closer look at our dermatome man again. That x-ray, that live x-ray where we injected the dye and you could see the spread of medication can hopefully gave you a visual of what the medication is doing as it's infusing into the epidural space. It will cover that targeted area of those dermatomes. On that patient, it was T8 and T9 to provide pain relief post-operatively. And with that said, and we'll go into this a little bit more, but by seeing that medication being distributed, you can get an idea of maybe what the medication would do should the catheter be to the left side or to the right side. You would not have equal distribution, and so a patient's assessment or sensory assessment and dermatome level might be a little bit about the epidural solutions that we use here at Dartmouth and how they work. So one of the ingredients in our solutions is something called bupivacaine. It is a numbing medication, a local anesthetic, and ultimately the way that it works is it binds to sodium channels and prevents an influx of sodium ions into the nerve cells. It prevents a generation of action potentials and conduction of nerve impulses, ultimately preventing the pain message along the spinal cord. So the pain is interrupted, and the area is actually numbed up with the use of bupivacaine. So when we use bupivacaine, we actually have the potential for nerve fiber blockade. So with that said, bupivacaine actually provides a sympathetic block, which can ultimately cause a little hypotension or bradycardia. It can also provide a sensory block, and that's really our goal. We want that bupivacaine to be put right into that specific epidural space related to that specific dermatome that we want to target. And so yes, we do want decreased sensitivity along that dermatome. The issue arises when we have sensory issues in other parts of the body, which could indicate that maybe the catheter has migrated. Bupivacaine also has the potential to provide a motor blockade. However, this is typically unlikely because the motor nerve fibers are the largest fibers and not likely to be affected by the bupivacaine. And so that's where we want to assess our patient's motor function. If there's muscle weakness or they're unable to ambulate, this could be an indication that perhaps it is too much medication that is hitting the nerve fibers. In addition to bupivacaine, we also provide dilaudid and or fentanyl within the solution. A combination of bupivacaine and an opioid is optimal because they work synergistically to provide better pain relief than either drug can achieve alone. We do make alterations depending on the side effects certain patients feel, which will be discussed in a little bit, but ultimately, dilaudid and fentanyl, typically they stay within the epidural space, so they're not systemic opioids that you would get from as if you were injecting dilaudid or fentanyl through an IV. Instead, this medication works more within the epidural space. It binds to opioid receptors in the dorsal horn of the spinal cord, and it blocks transmission of the pain message to the brain. These opioids don't have any effect on the sympathetic, sensory, or motor nerve fibers that the bupivacaine has an effect on. And so with that said, a thoracic epidural assessment is essential to patient care. So why do we do these assessments? Well, we want to make sure that the catheter hasn't migrated. or that the patient is not receiving too much of one of the medications, and it's ultimately to promote safety and improved patient outcomes. And that is why we do our epidural assessments. And so we'll go through each assessment and just identify some of the things we may have the patient do. So in terms of a motor assessment, what we're doing is really assessing whether or not that the motor nerve fibers have been affected. So ask the patient to bend their knees and lift their buttocks off the bed. A great way of assessing motor or doing a motor exam is have your patient get up on their feet and see how they handle that. Are they walking? Are they ambulating? Are they able to bear weight? If that dermatome is affected with the medication that we're putting in that targeted area in the epidural space. So does the patient have numbness or tingling in any other area of their body aside from their abdomen that we want numb? We want the abdomen numb in bilaterally, so that the patient gets pain relief. But is the patient having numbness or tingling anywhere else? If so, maybe that's an indication that the catheter has migrated. In addition, is there increased drainage at the site? This would be signs of infection, would also include a reddened area, erythema, purulent drainage. These are all things that the acute pain service would absolutely need to be aware about. And so continuing on, performing a dressing assessment. Is the dressing intact and inclusive? So we want the dressing completely intact and occlusive. So what that means is that the dressing that is over the insertion site is not rolled up and it is flat to the patient's back. If you're finding any rolling of the dressing, you can just reinforce it with Tegaderm. In addition, we want to assess the patient's vital signs, because what we're assessing is, are those sympathetic nerve fibers blocked? Is the patient slightly hypotensive? In addition, we want to also assess respiratory status. However, the incidence of respiratory depression occurs far less often than when giving enteral or IV opioids. And so thoracic epidurals are a safer way of providing pain medication. And then, of course, pain assessment. Is this current regimen working? Is the patient in pain? Is the patient able to perform their ADLs, their activities of daily living, in order to get better? If they're unable to, perhaps we need to make a change in the pain regimen. And lastly, we do want to assess the sedation scale, the POS scale, just to assess whether or not the patient is increasingly drowsy. And so let's discuss some risks and complications of epidurals. One of the risks is the insertion site infection. Some signs and symptoms of that would be back pain, fever, headache, erythema. In addition, an epidural hematoma can occur, although it is rather low risk in terms of complications. 1 in 150,000 people have had or experienced an epidural hematoma, but the issue is that it can lead to spinal cord injury and it needs to be addressed immediately. Epidural hematomas are oftentimes associated with inappropriate heparin regimens. So what that means is maybe taking an epidural out prematurely, like right after heparin has been given. That would increase the risk for an epidural hematoma. Epidural abscess is another type of risk and complication of an epidural. Back pain, fever, neurological changes are all indications that perhaps something's going on around the spinal cord. In addition, a spinal headache or a post-dural puncture headache, that would be the result of an inadvertent intrathecal catheter placement, also known as a wet tap. The acute pain service would be following that patient quite closely, and oftentimes this type of complication is a incredibly severe headache. Is some symptoms of toxicity include numbness around the mouth, ringing in the ears, or a metallic taste. All symptoms that the APS team would love to know about if your patient experiences any of these. So let's discuss the benefits of epidurals. So epidurals provide better pain management than systemic opioids, that we already discussed that. In addition, it actually improves gastrointestinal function. The opioid within the solution stays primarily within the epidural space, and because that sympathetic drive is blocked, the body basically sends all of its attention to the parasympathetics, which basically controls gut function and promotes gut function. And so the parasympathetics are not blocked, and patients with epidurals are actually known to have improved GI function compared to those receiving IV or oral opioids. In addition, epidurals reduce the risk of post-operative MIs and decrease the risk of post-operative mortality, which in my book is a very big win. And lastly, epidurals are also shown to decrease the severity of persistent pain syndrome, such as that in a post-thoracotomy pain patient. So now let's talk a little bit about some side effects of epidural solutions. So because the sympathetic nerve fibers can be blocked, hypotension can be a side effect, but hypotension is also something that needs to be assessed in regards to a patient's fluid status, because they are post-operative after all. So if your patient is hypotensive, don't immediately blame it on the epidural. Really look at their urine output and their overall fluid status to see if maybe the patient just needs a little more volume. Pruritus is another side effect of epidural solutions. The hydromorphone in the solution is known to cause pruritus, and Nubane is the medication that we have available in the epidural order set, and it's typically available as needed that you can provide to the patient. If it becomes intolerable, we can always take the opioid out of the solution. Nausea is another type of side effect, and again, that can also be caused from the opioid within the solution, and we can easily take that out. We do try and avoid taking the opioid out just because, again, the medications work better due to their synergistic effects, but in certain patients, and this is all part of providing individualized care to patients, in some patients we have to do just that and remove the medication that is causing the side effect. And anticoagulation and epidurals raises big red flags. Anytime you see any type of anticoagulation, your spidey sense should go up, your red flags should go up, because there is a risk for epidural hematoma when anticoagulation is used inappropriately. And so our neuroaxial infusion procedure states that APS should be contacted before initiation of any anticoagulation, including IV heparin, Coumadin, Lovenox, that is greater than 40 milligrams, or given twice a day instead of once, or any type of antiplatelet agents. But why does this matter? Well, this matters because it will dictate how we manage the epidural. We don't want to put a patient at risk for bleeding, for an epidural hematoma, which could be devastating to a patient. So having that conversation before starting anticoagulation is going to be safest for the patient. And so let's review just some troubleshooting kind of situations. The purpose of that is we need to assess whether or not the catheter can be removed based on the patient's anticoagulation status, and also we need to weigh the risk and the benefit of removing the catheter versus keeping the catheter in place. So it's very patient dependent. What if the catheter comes out? What do? Maybe you were in the process of getting Bob up from the chair back to his bed, and somehow with all of the tubes and the lines and the drains, his catheter slips out from the dressing. What do? You call the acute pain service immediately. Why is this worrisome? This is worrisome because, going back to the risks and complications, again, that risk for an epidural hematoma should the patient's anticoagulation status be compromised. How do I change the epidural bag? How often do I change the epidural bag? Every 24 hours. You'll need to order any medication with an opioid in it from pharmacy, and we suggest also putting a MAR note indicating its new expiration date and time. Can I increase or decrease the rate of the epidural per the order? Yes. So you can increase and decrease the medication as long as it's consistent with a rate dose change that APS puts in. However, this is not a titratable medication that you can titrate on your own. This has to correspond with the order that's in the MAR. And what if the pump says low battery, or it just shuts off and all of a sudden my patient is in a lot of pain? What do I do? Well, no need to call the anesthesia resident. This is all something that you can actually do yourself. Just open the top lid, replace the batteries, close and lock the lid, press the power button, which is on the right side, and turn the pump back. Regular IV tubing that needs to be changed every 96 hours. An epidural catheter tubing is placed under sterile conditions, and it is very rare that we would ever have to access that catheter. And so with that said, research has shown that there really is no benefit to changing the tubing at all. So reopening the tubing or changing the tubing just poses a risk for infection. And because the catheter is not sutured in place, we must ensure it does not come out. So leave all of the dressing changes to APS. But in fact, let's talk a little bit about dressings, because that's part of your assessment. So I'm going to show you a series of pictures, and I'd like you to indicate whether or not this is a yay or a nay dressing, a good dressing or a not so great dressing that needs to be changed. And so this dressing here, I would say that this is a nay. The tubing is exposed, which isn't necessarily an issue in terms of it being sterile. It plays more of an issue, or it's more of an issue in regards to the risk of it getting pulled out. So I would prefer that tubing be that dressing be reinforced and the tubing taped back down to the skin, or the tape that's there. And that tape that's there underneath the tubing, that's just for skin protection. But the dressing, everything is contained within the dressing, and the dressing is occlusive. There are no rolled up edges. The site isn't exposed. I would just leave it right as is. This one is a good one because this dressing looks pretty angry. That is a lot of dried blood underneath the dressing. However, the dressing remains occlusive, and that again is the key. We would rather keep the dressing occlusive when it was placed in a sterile environment rather than exposing the insertion site and running the risk of accidental catheter removal during the dressing change. So we did not change this dressing. It was secure all along the edges of the dressing. The only thing I would have changed is that when we placed that dressing, we would have shaved the patient's back. And so what should I be thinking about in regards to giving an anticoagulant or an antiplatelet to a patient with an epidural? Well, it's important to discuss anticoagulation and the timing of removal of epidurals. And so anything like heparin, Coumadin, Pradaxa, Xarelto, Eliquis, Plavix, Pleatal for patients with an epidural is a big red flag. We do try and time the removal of epidurals based on the last time the patient received one of these anticoagulants. And in addition, there should be a 1 hour window let me back up. After an epidural is removed, let's say our epidural is removed at 1:30 in the afternoon and you have a 2 o'clock heparin, sub-Q heparin dose to be given. The American Society of Pain Management recommends that you wait 1 hour before giving that sub-Q heparin after epidural removal. So it's really important for the acute pain service to communicate with the nurse and for the nurse to receive that information and understand its importance and why we request that heparin be held for a little bit of time after removing an epidural. What if my surgical patient arrives to the ICU with an epidural and he or she is intubated and sedated? Do I start a fentanyl drip for pain control? So I've run into this situation multiple times with my ICU patients. The patient has a perfectly good working epidural, but because the patient is sedated, can you really get a neuro exam per se or a motor exam? Well, ultimately, this is a very individualized decision. What's important here is that a discussion be facilitated with the team about what is best for the patient. And of course, involving APS in those discussions is also will also be beneficial. And so in conclusion, the American Society for Pain Management Nursing recommends ongoing nursing education related to epidural management to ensure competency and enhance knowledge. So therefore, this education session was developed using evidence-based resources to ensure best practices when working with this population. This is not the end, but really the beginning. While the Capstone project is coming to a close, we have exciting things to come in regards to epidural teaching and follow-up epidural education. The purpose is to enhance applied knowledge of epidurals in order to think critically when it comes to managing your patients and caring for your patients. And so with that said, the following things will be to come in the next few months project and deserve the utmost thanks. Of course, my mentor, Kim Hill, Professor Hall, and you, my classmates, for your feedback. I really appreciate any constructive criticism that you can provide. And we are almost there at the end, and I appreciate your time in listening to this presentation. I know it was a bit long, and it is a work in progress. Cheers to almost being done. So I thank you for your time and attention, and I look forward to hearing everybody's presentations.